Okay, good afternoon, everyone. My name is Nico Jansen with the Office of the Insurance Commissioner. This is the Palliative Care Benefit Work Group meeting, our second meeting, and I want to welcome everyone. Thank you so much for joining us today. So I know that it's been a couple of months since this work group, all of us got together, and I hope everyone had a good summer. So I'm going to get the meeting kicked off before we get into it with our land acknowledgement today. We are meeting virtually from Olympia and Tumwater on the traditional territories of the Coast Salish people, specifically the Nisqually and Squaxin Island peoples. Olympia and the South Puget Sound region are covered by the Treaty of Medicine Creek, signed under duress by the Coast Salish people in 1854. The OIC and Washington State employees respect these lands and tribal sovereignty. We acknowledge that the tribal governments and the Coast Salish people living on and taking care of these lands. Okay, so I'm gonna go over the agenda. You have the agenda screen shared, so hopefully you can all see that. So this afternoon, what we'd like to do is, based on some of our discussion and feedback at our first meeting in July, there was an interest, which certainly OIC shares, and other folks in the work group, to hear about previous reports that are specific to a state palliative care benefit. And we're going to hear more about those reports today from two excellent presenters who have both been involved in palliative care issues through those efforts. So that includes Beth Bojkoff at the Foundation for Healthcare Quality and BRE Collaborative, and Dr. Sophie Miller with the Healthcare Authority. So after that, I'm going to provide an update from OIC's perspective about the procurement that we're doing in coordination with this work group, tell you where we are, and then tell you what we're thinking in terms of the future work group meetings and the future next steps. So that is our agenda today. Before we get into the presentations, I'd like to do a few housekeeping items for the Zoom logistics. As a reminder, and as indicated when we started recording, we are recording this meeting and the other meetings of this work group. We are posting those meetings on OIC's website, and they are going to YouTube from there. These meetings are open to the public in addition to the formal work group members. And we post information about this work group on OIC's website. Any content that anyone as part of this group is sharing, I'll make sure to let you know and get your permission before posting that. In terms of the Zoom functions, there is a closed captioning service on Zoom for everyone. Raising hands is probably the best way. If you have a question, you can also use the chat. I'll do my best to monitor the chat, and my OIC colleagues who are on today will help me with that in terms of the chat and raised hands. Okay. And lastly, I'll say, so we have a 90-minute block today. I don't know if we're going to need all that time. We might, but I want to make sure that we have plenty of time after the presentations. Okay. So for our first presentation, I'll just say in my research, preparing for, OIC's role in this work group, convening all of you, it's been really helpful to know that there's been a lot of background research done that's specific to the state. And, I've looked at the BRE Collaborative report and the OHSU and HCA report because a lot of the kind of considerations that the legislature is asking this group collectively to come up with regarding the clinical eligibility criteria of who's eligible and when that eligibility starts, the services that would be included in a benefit, the staffing models and staffing issues, and the issue of payment methodology, to me are issues that these previous efforts have addressed. So my goal with these presentations and today is for the work group members, some of whom I think have been part of these other efforts and probably have a lot of knowledge about them, but everyone to have a good base understanding of where these reports landed on some of these issues, the recommendations they gave to give a base understanding for us and what we're doing for our purposes. So we will start with Beth Bajkov, and Beth is with the Foundation for Healthcare Quality and BRIE Collaborative. And Beth is an RN. I'm so excited to hear from Beth today. And I'm going to start by stopping the slide sharing of the agenda and sharing the slide. Okay, looks like that's in presenter view. So let me just change that so that we're seeing. Okay, Beth, is that looking correct to you?
Yeah, I think that's right. Great. If you wouldn't mind just backing up one slide, I'll introduce myself, and then my colleague is with me today, so she'll be helping. Hi, everybody. My name's Beth, and great job on my last name, actually. Nico, appreciate it. I use she, her pronouns. I am the Director of Research and Best Practice at the Foundation for Healthcare Quality, primarily supporting the BRIE Collaborative. In my role, really, I joined the organization after this report was already written and adopted, but my role in the organization is to support the development and publishing of these reports and guidelines each year by the subject matter experts that the BRIE Collaborative convenes. And I'll pass it to my colleague, Dr. Emily Noodleman, to introduce herself.
Yeah, hi everyone. It's great to join you all today virtually. My name is Emily Noodleman. I use she, her pronouns, and I am the Transformation and Community Partnership Manager at the Foundation for Healthcare Quality. In my role, I primarily support the implementation of BRIE reports into practice settings, and I also support some of the health equity work within the organization. It's a little confusing. The BRIE Collaborative is housed under the Foundation for Healthcare Quality. So that's where you kind of see maybe Foundation for Healthcare Quality, or you see BRIE Collaborative. But Beth and I both support the BRIE Collaborative program, and we were asked to come today to talk a little bit more about the palliative care report and the guidelines. So as we jump in on the next slide, we just wanted to provide an overview, an introduction to the BRIE Collaborative. So the BRIE Collaborative was developed in 2011 by Washington State legislation so that public and private healthcare professionals would have the opportunity to identify specific ways to improve healthcare quality, outcomes, and affordability in Washington State. They are appointed by the governor as collaborative members and represent different sectors of the healthcare ecosystem, such as hospitals, clinicians, health plans, purchasers, among others like the Healthcare Authority. Each year, our members identify healthcare services with high variation in the way that care is delivered, that are frequently used but do not lead to better care or patient health, or that have patient safety issues or inequities. On the next slide, we wanted to just provide an introduction to the BRIE Collaborative process. So once our BRIE members identify and choose a topic, it will become the focus of our work for the next year. The BRIE Collaborative forms a work group of subject matter experts to develop the report that provides information and guidelines for actions different audiences can take within our healthcare ecosystem to improve the care for that topic. So you did hear me talk about BRIE members. Those are appointed by the governor. However, these work groups are an opportunity for members of the public to participate and engage in. We facilitate those work groups, specifically Beth leads that development so we can create these reports. It usually takes about a year, give or take, for the report to be developed and finalized. Commonly, we focus on about 3 different topics to develop a report on each year. So in 2019, our focus was on palliative care as one of those topics. BRIE Collaborative does have guidelines within those reports. These are also known as recommendations in our earlier reports. So we really see these guidelines as actions to be taken to improve healthcare for the specific healthcare services, such as palliative care. On the next slide, you'll see we have different report audiences. So each of our reports have specific audiences that we've developed these guidelines for. Within the palliative care, these are the ones that are represented on your screen. So health plans, purchasers, clinicians, health systems. Those are commonly really seen within the majority of our reports. And then sometimes there might be like a special or specific population. So such as within our palliative care report, you can see we had specialty palliative care teams. That's unique to that topic, so that's not going to be seen in all of our reports. But we do try to be really inclusive of different audiences to the best of our ability. And so we'll talk a little bit more specifically about that report, and I'll pass it to Beth.
Thanks, Emily. Excuse me. Thank you. So now I'll review a little bit more in detail the actual contents of the palliative care report and recommendations. And we'll drop a link to this report later on during the presentation. But the report can also be found on our website under the guidelines tab under the managing pain category specifically. Next slide, please. Great. So to start off, the aim of this work group really was to develop best practice recommendations for palliative care regarding the assessment of patients with serious illness for primary and or specialty palliative care need, care delivery frameworks for palliative care, and payment models to support the delivery of care. And the final report and recommendations were adopted in November of 2019. Next slide, please. So this is all to say, you can see the chair was from Dr. Robinson from First Choice Health, but really something to just keep in mind is this really, this work group involved a variety of professionals from across the state, from across different disciplines, physicians, social workers, health policy professionals, public health professionals, and different roles to kind of come together and develop these really collective action guidelines for palliative care. Next slide, please. So the work group developed the following focus areas to increase accessibility and quality of palliative care in Washington. And that included defining palliative care using the standard definition developed by the National Consensus Project, so really endorsing and adopting that definition. Spreading awareness of palliative care, what it is, and the clinical best practice provisions of palliative care that are responsive to local cultural needs. Include advanced care planning as outlined in our 2014 end-of-life care pre-collaborative report and recommendations, which include things like appropriateness of advanced directive and physician orders for life-sustaining treatment or post or a similar suitable document, and best practice provisions that incorporate goals of care conversations into the medical record and plan of care. Another focus there, the final one, was increasing the availability of palliative care through revision of benefit structures, such as a per member per month benefit, which we will discuss in more detail. In the report, the work group members really identified barriers to access as well, specifically highlighting lack of adequate reimbursement as a primary barrier to adequate provision of palliative care. So the interdisciplinary team that's required for this, not all of whom can bill for services, and an emphasis on care occurring outside of the face-to-face visits, such as care coordination. Those really aren't supported within a fee-for-service system, and that's still true to this day. Next slide, please. Great. So I'll go over a little more detail about the first focus area definition. So the work group adopted that definition of palliative care for the National Consensus Project, which really is focusing on palliative care focuses on expert assessment and management of symptoms, assessment and support of caregiver needs, and coordination of care, attending to physical, functional, psychological, practical, and spiritual considerations of a serious illness. It's person and family-centered approach to care and providing people with serious illness relief from the symptoms and stress of an illness. And as you can see at the top, serious illness is defined as a condition that negatively impacts quality of life and daily function and or is burdensome in symptoms, treatments, or caregiver stress and carries a high risk of mortality. So the work group really recognized while palliative care grew out of the hospice movement, palliative care is distinct from hospice care and applicable to a wider population of people. Oncology has really been an earlier adopter in providing palliative care, but access to that remains inconsistent even within oncology and especially for diagnoses outside of cancer. And palliative care is largely offered in larger not-for-profit urban hospital settings, at least at the time the report was written. So as you can see in the figure on the right, while hospice care is generally only available to people with 6 months or less to live, palliative care can be offered alongside life-prolonging or curative care. And for some, palliative care is followed by rehabilitation and survivorship, while for others, it leads to hospice and end-of-life care. So you can kind of see in that figure the work group developed. Next slide, please. In addition to the definitions, the National Consensus Project also defined some ideal components of palliative care that are included in the assessment and ongoing management. But first I'll kind of describe the two forms of palliative care that the work group delineated. So they identified primary and specialty palliative care as being a bit distinct. The palliative care team should be able to deliver all principles of palliative care within primary care or a relevant subspecialty like cardiology, to meet the physical, functional, psychological, practical, and spiritual consequences of a serious illness, and be able to refer patients to specialty palliative care when their needs cannot be met in that setting. And specialty palliative care really is provided by an interdisciplinary team that includes or has access to care coordination, and is able to meet medical, psychological, and spiritual needs. They recommend highly that this specialty palliative care has access to 24/7 specialty expertise, and often can be provided in hospital inpatient settings, outpatient clinics, within hospice agencies, or the community. Next slide, please. So I'll go a little bit more in depth into this interdisciplinary team under the specialty palliative care. As I've heard it, that sounds like it's also an important component for determining the benefit structure. So the Consensus Project defined this team as including physicians, advanced practice registered nurses, physician assistants, nurses, social workers, chaplains, and others based on need. And they delineated kind of the roles for each of those professions. As you can see in this table, physicians really responsible for managing and monitoring illness trajectory, prognosis, and medical treatments. Nurses looking at patient assessment, direct care, being a patient advocate, care coordinator, and educator. Social workers really supporting those family dynamics, assessing and supporting coping mechanisms, and assessing and supporting social determinants of health, identifying and facilitating access to resources, and mediating conflicts. Chaplains being the spiritual care specialists, assessing and addressing spiritual issues and facilitating continuity with the patient's faith community. And clinical pharmacists really in charge of medication management, adjustment, and deprescribing. Next slide, please. The work group defined also the steps for initial assessment and ongoing management under the specialty palliative care team in the recommendations. Again, some of which or all could be delivered in primary palliative care. So at the initial assessment and ongoing, the team should discuss goals of care, reassess regularly as they may change. Those goals may change over time, including clarification of those goals around hospitalization and the need for long-term care. Conduct advanced care planning conversations and documenting them with easily understandable and culturally appropriate advanced directives, including living will, durable power of attorney, and written personal statement on articulating values and goals of end-of-life care. Again, reassessing those regularly. And then in assessing, addressing some of those other needs, including cognitive impairment, practical consequences of serious illness, such as having difficulties with activities of daily living and connecting with community resources, assessing and managing symptoms of serious illness that impact quality of life, assessing the medication list in conjunction with a pharmacist, caregiver stress, capacity, and support, offering support to caregivers as they're able, assessing and managing behavioral health symptoms related to serious illness, including the screening with validated instruments for depression, suicidality, and anxiety, and explaining the purpose of screening, and assessing and discussing spiritual care needs, ideally with a board-certified chaplain with specific training in palliative care. In addition to the above items that team is responsible for in primary care, as I said, some or all could be delivered, but especially in the primary palliative care, patients should know how to contact their primary care provider or team with questions or urgent issues. And if the patient's needs become greater than can be managed in that setting, there needs to be the ability to refer to specialty palliative care. Next slide, please. Okay, so we're getting into a little bit more of the meat here. As I stated at the beginning, lack of adequate reimbursement was identified as a primary barrier to the adequate provision of these services of quality palliative care. So the work group emphasized revising the benefit structure to include A per member per month benefit for patients with serious illness that's open to all ages and follows patients across care settings, doesn't require being homebound, and sets the provision of specialty care services as the accountable entity for this. Next slide, please. So part of that benefit structure also includes developing an agreed upon strategy to identify seriously ill patients, such as with PAXI, I believe I'm pronouncing that correctly, eligibility and tiering criteria, which is referenced in our document in an appendix, requiring the interdisciplinary approach to care that doesn't include a requirement for the physician to lead the care team. And offer larger payments for initial intake, a per member per month payment, and a smaller per in-person visit payment. Next slide, please. And so you can see this list was included under both the health plan and healthcare authority stakeholder specific recommendations to make sure that we're covering under that benefit all of the quality of care requirements that were outlined earlier for the care teams. So that initial assessment, goals of care conversations, advanced care planning, assessment, and ongoing assessment and management of cognitive impairment, functional needs, symptoms, medical management, pharmacy, caregiver support if needed, behavioral health, psychosocial needs, spiritual care needs, and others as needed. And they actually also included and recommended to define excluded services such as hospitalizations for unrelated diagnoses. And I'll move on to the next slide here. So finally, I just wanted to cover a little bit about some of the metrics that were also recommended by the work group. The work group highlighted that comprehensive quality metrics for adults with serious illness need to be really feasible and under the control of those being measured. And so they didn't recommend specific metrics, but they wanted to highlight that at least one metric be identified and utilized under each of these categories. So you can see the first being potentially avoidable complications, or could be operationalized as readmissions, depending on the specific audience. But the work group identified a couple potential denominators under that, which really tie to service utilization, like number of ED visits or hospitalizations or readmissions in the last 30 days of life. Really noting that those aren't never going to happen, but the fewer the better, and the fewer, the more likely that we're improving patient and family care. And then second, patient-specific quality of life, which they reference the NCQA measure that's most commonly used, which is percentage of adults 66 years and older who had advanced care planning, medication review, functional status assessment, and pain assessment during the measurement year. And at the time of the report writing, they highlighted Colorado, Illinois, and Rhode Island had included that metric in contracting tied to performance. I'm not sure if that's still the same today, but at the time the report was written, that is what they noted. Happy to answer more questions, but I'll turn it back over to Emily at this point.
Great. We can go to the next slide. So we want to just review a little bit too about how we recommend using a report for the Bereave Collaborative. And so we recommend that you review the section that best identifies with your organization or the group that you work with. We recommend that you familiarize yourself with other audiences. So if you're a health plan, you look at your health plan section, but it's also great to know, like, what are we asking from clinicians? What are we asking from health delivery systems and so on? We recommend that you assess your work and kind of see where you're at compared to the guidelines. We ask that you prioritize at least one guideline that you feel like you can commit to and implement into practice. We recognize too that, like, it's hard, right? When you look at these guidelines, you're like, Emily, you're asking me to do like 20 things. Like, I can't do all 20 today. And you're already balancing in your work and life that, like, there's so many asks out there right now. So that's where we just hope that you can kind of find some aspects of the report that you feel like, you know what, today, this is where we're at. This is a starting point that we can grow into and really commit to and move forward and work on implementing. And then we hope that you can also evaluate your work to see what was the outcomes, the impact, and where can you move forward to. We do hope eventually you can do all the guidelines, but again, just being able to start is huge. On the next slide, you can see this past like end of May, the BRIE Collaborative worked really hard to develop an implementation guide that's accessible online. In the implementation guide, we have each of our reports listed, and then they all look kind of like the same format you're seeing on the screen. So this is for the palliative care report. There's guideline information. There is on the read online, you can access it that's okay. You can access the report online, resources and tools that exist out there that we are aware of. We've added to this. We also welcome other ones. If you're like, I really love this one, send it my way, and I'm happy to add it. We're working on developing metrics and evaluation tools. And then you can see there's also a portion on examples of implementation. We're hoping and working towards developing different case studies of success stories that organizations have been working towards implementing practices and adding those as we learn those and get those. I think in an area that we've seen success with the report, and the DOH did a really great job with palliative care and doing a roadmap on that. And so we can work to put that link in the chat if you haven't seen that. I think Cora kindly posted that in the chat as well as the URL to our palliative care report. But I know members of the DOH are really leading that work within their sector and developing that document. On the next slide, you'll see something that the BRIE Collaborative has also been working on is just an awards program. Again, so many times in our healthcare system, we're asked to do so many things, but we also want to like celebrate successes and celebrate people doing great things. So we have different awards that we provide. There's information on the screen, and we can also add a link to that if you're interested in that. But we can provide the Pathfinder Award as work is being implemented a little further, the Trailblazer Award, and even more. A greater commitment is the Mountain Climber Award. On the last screen, we just want to invite you all to an upcoming event that we are hosting. We're hosting a Social Need and Health Equity Summit in about 2 weeks. This is a virtual event on Thursday, November 7th from 9 to 12:15 p.m. It's virtual, it's free. CME is available also free of cost, and we're really focusing more on just a lot of information under social needs and health equity, such as how, if you're screening, what are interventions and who's doing this and how does it look like for their organization? People have been asked to talk to ACHs and build relationships with ACHs. What does that look like? We're going to talk about it. You've been asked to capture SOGI data and do some work around that. We have groups talking about that and on case management updates. So, but really we're excited to hear from our plenary speakers, Edwin Lindo, who will be talking about health justice and the sustainability of health equity for the first hour of the event. And on the very last page is Beth and my email. So if you want to get in contact, we're here for you. The best way to stay up to date with our work is honestly just joining our listserv. We try to send out a monthly newsletter. That's the best way to figure out what's going on with the BRIE on all of our topics in our work. We also try to share like, hey, we're going to this event. If you're there, come say hi to us. We love the opportunity to meet you in person. So that concludes our presentation. So if there's any questions, comments, we're happy to do our best to answer those for you with the remaining time.
Okay, thank you so much, Beth and Emily. That was wonderful. I certainly have some questions, but I am going to defer to others first. And I also recognize some names on the BRIE Collaborative work group from some people who are in this work group. And so, I sense some overlap in the issues they're grappling with. And really, what we were trying to do is provide some more concrete actuarial analysis for a potential benefit and what that would look like. But I think that this work gives us something of a starting point. So let me open it up to our work group members. Does anybody have questions or comments on what Beth and Emily presented? And excuse me, feel free to raise your hand or just unmute and begin talking. We can do either way.
So I actually have a question for this is Jane Byer at OIC.
Hi, Jane.
So for the BRIE folks, I definitely hear you when you say it's sort of like working with organizations to implement pieces where they can. given that everybody wants providers to do 15 different things.
Yes.
But if here we're talking about how we design and price sort of a good palliative care benefit, then we could be in a situation where, yep, we're going to say that if a health insurer is going to pay for palliative care, then because we want to make sure that we're getting value out of what we're asking insurers to pay for, we would want the benefit offered as, for example, this is structured, or I know we're going to hear from OHSU, especially if we're talking about alternative payment models. So how do we balance if we're going to pay for it, we want to know that what we're paying for is a high quality benefit against this isn't a do it overnight kind of an implementation for a provider?
Yeah, I think that's a great question. I don't know if I have the full answer for you, Jane, but I'm happy to kind of try from different. From what I've heard is it's been really hard to get the buy-in from the clinicians because there's not a payment. They're not being paid for it. So I think having that payment will help be the motivator. And by having that payment, then we can describe what components need to be in there, specifically looking at the BRIE collaborative report of what we have been asking for them to do. And then if there's a way to move to the per member per month and add those different components that we're saying are the best practices for those members, that would be a step forward.
So it's kind of a chicken and egg thing.
Yeah,
A little bit.
I think it's always a game, right? Like you can ask somebody to do something with the best intention and they are happy to do it if they can feel motivated, but they'll be very motivated if they're paid or required to do it.
Thanks.
Hi, Dr. Fausto. Looks like you have a question. Please go ahead.
Yeah, so thank you both for presenting. And I realize you can't present the whole report and the whole thing. And so I wonder, and I also have some suspicion you may not be in the report itself, but I think one of the most difficult things this group is going to face is determining inclusion criteria, like who is part of the benefit. And I'm wondering if you all, beyond a definition of what palliative care is, ran into discussions of like, if this were a benefit or if it were to be provided, some boundaries around inclusion and exclusion.
Yeah. I off the top of my head, since I also wasn't necessarily present for those those meetings, but I can dig a little bit deeper into the report and get that answer for you later on. I don't see it off the top of my head from skimming it, but it may have occurred and then through the process of revision, got left out. But
Okay, thank you.
Jim, I'll just comment quickly. I was on that work group, and to the best of my recollection, we didn't put inclusion criteria into the BRIE report, but we referenced PAXI, which came out of the American Academy of Hospice and Palliative Medicine, and I believe the PAXI model does have inclusion guidelines.
that's right.
Thank you for bringing that forward. That also just makes me want to clarify something. Something in the BRIE report too is that we uplift other organizations. So if it's maybe we will not create the criteria per se, or we might not tell you how to diagnose somebody with treatment for OUD, but we can uplift where that does exist and has been published and been formalized. And so that's something that our work group members will review and do. So we'll try to see if we can grab that PAXI link. Oh yeah, I think it's
in Appendix D of the report too.
Let me see what page that is.
Yeah.
I think it's on page 31 of the document. Yeah. Or 29 of 33.
Yeah.
Ryan, do you have a question or is it?
Yeah, go ahead, Ryan.
Yeah, or sorry. So if I'm rambling or I'm just kind of thinking out loud. So
No.
I'm representing the home health agencies, along with some hospice items as well. And
Yeah.
so when I think about palliative care, I think a lot of crossover between both of those organizations. But some of the issues that we are dealing with right now is Medicare Advantage or Medicaid plans pushing back on what would be historically a solid home health case, such as like a bed-bound catheter patient. Homebound, bedbound catheter patients where they're saying more that's chronic care, or even some of the hospice items as well. How how do we move forward with what should be a simple home health or hospice case? And are we trying to create kind of a workaround to get those kinds of cases that might fall in palliative care now? Some of those chronic care items, some of those intensive cases that, like I said, would historically be considered a home health case or even a hospice case now is falling under a different category. Maybe I know it's kind of a winded question, kind of thinking out loud. Like I said, does that make sense?
I think your question makes sense. I don't think it was a focus of the report. And so I would love to be in the discussion to hear that answer, though. I think that's a fascinating point that does need to be thought out, and think of that collaborative space where how do we deal with that pushback, and how do we, at the end of the day, provide optimal care for Washingtonians to receive palliative care. You're correct in your statement too, where commonly palliative care and hospice are combined. However, also, as you're stating too, recognizing palliative care does not only exist with hospice, and there's other circumstances that maybe a person needs other support too. So I think that I don't recall that being part of this report. And the other thing I just want to highlight before our time's up is this was developed in 2019. So I would also recommend and encourage just looking into any updates that may have existed since 2019. We at the BRE Collaborative are slowly creating a process to review forward reports and see how we can update them. For example, we had a treatment for opioid use disorder report that was developed in 2017, and we've had a new work group this year who's been updating that report. So we're slowly making it through those processes.
And we take suggestions. So if you notice something in your space that, you think, gee, there was a report on this like 5 years ago, it'd be great to have, there's been a lot of change in the field. It'd be great to have a reconvening. Every year we look to the public, members of the public who are in these spaces, to give us good suggestions and ideas to bring to our collaborative and vote on.
Yeah, but it does seem a lot of the components of this report seem to still ring true.
Yeah.
Wonderful. Question from Chris. Go ahead.
Good afternoon. I'm Christopher Kunis. I'm with the Association of Washington Health Plans. Just quick question. I don't think the report was focused on other states, but are there other reports that have data from other states, and specifically I'm trying to drive towards what other states have implemented something like this? What were the problems they had so we can avoid those problems?
Great question. Also outside the scope of this report, within the BRE Collaborative, it is only focused within Washington State. We encourage other states, if they would like to look to it, to review that. But the BRE Collaborative being developed by Washington State legislation, it is for Washingtonians specifically. So that has been kind of the lead up. Sometimes we'll look into other states to see what they've been doing in different aspects of things in the development of this report. However, I can't speak to that specifically for this specific report, but I would encourage research in some other areas to see how that may align.
Thanks.
Yeah.
Okay. I am going to propose that we go on to Sophie's presentation at this point. I know there's a few other items related to this I'm thinking about in my head, but I think maybe they'll be addressed in Sophie's presentation as well, just looking at the time. But I think that Beth and Emily's contact information and this report is available in the chat. And we'd love to stay in touch with both of you and apprise you of what this work group is doing. And we just really appreciate the time. Super helpful. So thank you.
Absolutely. Thank you all for having us. It's been great, and we hope to stay in touch. So if you have any questions or comments, please reach out to us. But have a great day.
Yeah. Thank you, Bill.
Awesome. Thanks so much. Okay, so the next presentation I have lined up, which I think syncs with what was just shared from the BRE Collaborative, is the Healthcare Authority and Oregon Health Sciences University, OHSU, their report. And we have Dr. Sophie Miller with us from the Healthcare Authority to present on that.
Great.
And
hi, everyone.
Go
Can
ahead,
you hear
Sophie.
me? Great. Can you hear me?
Yep.
Great. And can you see my slides, but not everything else?
It looks like you're in presenter mode. I think if you go on display settings.
Okay, thank you. I'm a Teams person.
Swap.
So, swap. Is that better?
Okay, that's looking correct for me.
Okay, great. Thank you for walking me through
Thanks.
that, Nico. Hi, everyone. I know I've met a lot of you before in our palliative care work. My name is Sophie Miller. I'm a physician by training. I'm a hospitalist, and I'm also a medical officer here at the Healthcare Authority. And I've been helping out with our Medicaid palliative care work for the last couple of years. Thanks for having me here. Just wanted to talk through what our agenda is today for my portion of the presentation. I'm going to throw up a definition of palliative care that I think is an important one to consider. It might not be the one that everyone rallies behind, but it's a nice definition. I'll talk about the current state of palliative care in Medicaid, and then I'll dive into that report that everyone keeps mentioning, the so-called OHSU report. That report was put together in 2023 by the Center for Evidence-Based Policy, which is a group out of OHSU that we had contracted with to help us with that report. And then I'll close out by talking about our Serious Illness Institute that we've participated in through NASHP, which is the National Academy for State Health Policy. So here's the definition I wanted to talk about related to palliative care. And this one is from the Center to Advance Palliative Care, or CAPC. CAPC is a wonderful organization where we have really leaned on, we're members, and we really leaned on them for some of their expertise, workshops, et cetera. So this is a definition that they suggest for palliative care, and that is focused on providing relief from symptoms and stress of illness with the goal of improving quality of life for both the patient and the family. Ideally, palliative care is delivered by a specialty trained team of doctors, nurses, social workers, chaplains, and everyone works together with the patient's existing medical team to provide an extra layer of support. And palliative care ideally should be based on the needs of the patient, not necessarily on a specific prognosis. And it can be appropriate based on the patient or family at any age or stage of illness. So I'll leave that definition for folks to discuss a little bit later, and I'll dive into the current state. So right now, Medicaid does cover some existing palliative care relevant services. We cover comprehensive assessment and care planning for patients with cognitive impairment, of course, advanced care planning and end-of-life counseling. And then we also cover some care management and family support through our Health Homes program, as well as those evaluation and management, or E&M codes, that providers can bill. We have hospice coverage that includes care coordination, medications, and home health. Understanding hospice is very different from palliative care. And then we also have an existing pediatric palliative care benefit that is designed to deliver case management, pain and symptom management, counseling, et cetera, to those kids with life-limiting conditions with complex needs. We understand we have some areas for improvement here regarding Medicaid coverage for palliative care. We've heard that the services that we offer right now are pretty fragmented, so there's no real specific one benefit, and there's no leader of the care management team necessarily for palliative care. And then our benefit, what we cover right now lacks some key features of palliative care. And one of the things you've heard other folks talk about is services like chaplaincy, or more care coordination, 24/7 telephonic services, things like that. And then finally, as you've heard, the fee-for-service model of payment leaves out some folks from getting reimbursed for their services. And so that's another area for improvement. I just wanted to upfront talk about a couple of the challenges we've had with palliative care implementation. And one is funding, both for understanding what a benefit might look like for Medicaid, from an actuarial analysis and delivery of that benefit. We've also heard from providers across the state that there's workforce capacity issues. So I know the folks at Bree had referenced specialty-based palliative care versus primary palliative care. And in some areas, specialty-based palliative care just really isn't geographically an option. And then, of course, the stigma associated with palliative care services. And you'll notice some of the language used to describe palliative care is moving towards serious illness. That's actually a phrase that has been workshopped and looked at by a few different groups. And serious illness actually sits better with people than palliative care services. I'm not going to dive too far into the stigma. That's not really my role here, but just one of the challenges in uptake of palliative care and of implementing a benefit. So now I will move on to our palliative care reimbursement project, or the so-called OHSU report. This was the product of ESSB 5693, which passed in November of 2022 and directed the Healthcare Authority to design a standardized payment methodology for a palliative care benefit for the state Medicaid programs and the Employee and Retiree Benefits Program. Again, the HCA engaged the Center for Evidence-Based Policy at OHSU to help us with this report. In this collaboration, we did a review of existing literature and reports. We had sessions with stakeholders and key informants. Many of those key informants are sitting with us here today. And then we held some listening sessions. And really the goal of the report was to identify 1, eligibility criteria, 2, a defined benefit, and then 3, a payment model that might work for a palliative care benefit. So these are the report's recommended covered services. These might look very familiar to you because they really align well with what the folks at BRE just presented. So that's an initial assessment, goals of care, advanced care planning, assessment of functional needs, symptoms, cognitive impairment, as well as pharmacy support, caregiver support, and then assessment and management of things like behavioral health and psychosocial needs as well. And that spiritual care needs can be a tricky part of palliative care, especially since chaplaincy is a difficult way. It's hard to pay chaplains, and that's sort of what I will talk about later when I talk about options for payment. So these are the recommended covered services in the report. And then this is the eligibility criteria that was suggested in the report that's both based on that 2019 BRE collaborative report that we just heard about, as well as the PAXI suggestion. So this is a patient must have at least 1 serious illness or a combination of 3 chronic conditions, limited functional status, and then a history of unscheduled healthcare utilization. So just to add a little bit of additional layers onto that, the serious illnesses that are listed based on PAXI include metastatic cancer, heart failure with a pump device in the heart to help the heart pump, bad obstructive pulmonary disease, advanced dementia. And then some of the other like chronic conditions might be liver failure, end-stage renal disease, a history of multiple strokes, ALS, et cetera. So these are kind of the ideas for what might point someone to be eligible for a palliative care benefit. The unscheduled healthcare utilization might be either inpatient admissions or multiple visits to the emergency department. So moving on here for the payment option. So as I discussed, fee-for-service alone does not really support the delivery model of an interdisciplinary team working together. And so the report put together by the Center for Evidence-Based Policy recommended a hybrid model with fee-for-service components. Those are volume-based components for those E&M codes, the transitional care management or TCM codes, and end-of-life counseling, as well as an alternative payment model for the other services. So symptom management, care coordination, 24/7 telephonic palliative care services. And the suggestion was a per member per month payment. So that summarizes what we learned from the Center for Evidence-Based Policy work. And I wanted to share a little bit more about what we've been doing over the last couple of years. So Washington was selected to be a member of the State Health Policy Institute to improve care for people with serious illness as a member state under NASHB. And so we were selected from multiple states, and we are joined by Colorado, Maine, Maryland, Ohio, and Texas. And NASHB provides us with expertise and technical assistance in sort of trying to think about a benefit, a palliative care benefit. And then the part of the Institute that I found most helpful is it's provided a really nice venue for sharing strategies and solutions that have been utilized by other states that we can help learn from. And then, of course, ongoing review and discussion about what our current state is and options for a future palliative care benefit. So the 2 states I think that we've learned a lot from are Hawaii and Maine. Hawaii has been invited to speak to the Serious Illness Institute on a couple of occasions. You might be aware that Hawaii recently implemented a palliative care benefit under a state plan amendment for all of their Medicaid beneficiaries. And the design includes an interdisciplinary team with a grief counselor, and then it's paid on a per member per month payment structure, with DME and pharmacy kind of falling outside of that PMPM structure. And then Maine used their existing health homes model, which is a model we also have here in Washington. and expanded that to add an additional palliative care layer, again with an interdisciplinary team with behavioral health support and care management. The other thing the Serious Illness Institute has offered us is a data analysis to help us understand potential utilization of a benefit based on the population profile for palliative care or for Medicaid. And I understand that that is sort of underway for this work as well. And this includes also an estimated savings based on the assumption of decreased utilization of inpatient stays and emergency department utilization based on palliative care support. So right now we're kind of tossing around some benefit options. We're thinking about a possibly tiered approach based on patients' needs. So perhaps patients with lower needs might have access to a few services, and then patients who are identified with higher needs might have access to additional services. Those services will likely be through a team-based interdisciplinary team. You've heard that from multiple people now. And then thinking about a nurse-led model. And then finally exploring payment options such as alternative payment methods like the PMPM that I had mentioned. Our next steps in our palliative care work over on the Medicaid side is one, to understand the baseline data about who might be eligible for palliative care and what a benefit might look like, and then develop a set of options for either a benefit design or overall improved access to palliative care. So thanks for having me. I will, I think the OHSU report, I'm anticipated that people are interested in seeing that. That was linked in the agenda. Or someone dropped it.
It's in the chat too.
Thank you, yeah. So it's in the chat, and then I can pop my email up if people want to reach out to me over email, and I'll stick around for some Q&A right now. Thanks.
Thank you so much, Sophie. Any questions or comments for Sophie?
Sorry, can I ask, this is Jim Falso again. It seems that, like, in working with patients and families, one of the things they often describe needing the most is actually like some home health aid, like support with that. And I didn't hear it, like, in general, palliative care, I'm a palliative care physician, I lead a team at UW, like, we don't talk about home health aid in our definition in our work, but I think if we're thinking about a benefit, I think that's one of the powers of hospice, is that it does bring some home health benefit where that's not really an option for people. So I put that out there as a reflection that I didn't see it talked about. I wonder if you, Sophie, have any comments to share on that, or just generally put it in the ether, because I wonder about that element.
Thanks, Jim. That is really helpful, and it's something I hear from my patients too. Sometimes when I engage palliative care services in the inpatient side for complex symptom management, what the patient actually wants is home health. And I'm sure you've experienced that. So the problem with current home health services is that they are tied to a so-called episode of care. So you can refer, this, people are nodding. So for those of you who don't know, when a physician refers someone to home health, it has to be tied to a hospitalization. Maybe it's a month of home health, and then the home health expires. And so we are aware of that hole right now. And that is kind of one of the reasons why we're trying to figure out a benefit, is that people with serious illness need more support in their homes. And we don't want that support to necessarily be tied to an inpatient admission. So we are trying to sort that out. And that's definitely something we've thought about and heard from multiple people, but thanks for bringing that up.
Other questions, comments? Barb, go ahead.
Yeah, the other thing that goes along with Dr. Fausto's comment about home health aides is community health workers. And that is not typically a position that Medicare certified home health agencies or hospices have, but I think that's a position that needs to be included in any sort of palliative care benefit, because it's people who are doing community-based palliative care say it's vital. And again, I've mostly worked in Medicare certified home health and hospice programs, and have been director of both kinds of programs, and that just wasn't a job description that we had. But I do understand that it would be really important. And I'll defer to any of my colleagues who are in this meeting today to talk about that more. But I just know it's a need and a gap, and we can't just model this benefit based on what Medicare certified home health or hospice programs provide.
Thanks, Barb. And I will say that I am not an expert on community health workers, but my understanding from the Medicaid side is that we are working on getting that designation to be reimbursable, so those folks can get paid. We have not delved as far into what that would look like for palliative care, but it's certainly something that we've talked about in our internal meetings.
So Leslie had a comment in the chat about the
Oh.
difference between home care for activities of daily living versus home health for skilled nursing in the home. And that made me think of the fact that there is some level of long-term care benefit in Medicaid currently. However, for talking about commercial insurance, right, we don't have that. And so I guess I'm reading that to wonder, to what extent do services that could be considered under the palliative care umbrella fall under the existing Medicaid benefit for home care for activities of daily living that commercial might not be covering right now?
Yeah, I'm not sure if I have a great answer to your question. I think what Leslie might be referencing is the fact that home health, so skilled nursing is actually usually delivered at a skilled nursing facility and is another designation, but home health usually has the goal of rehabilitation. So that is, maybe someone has had a stroke and the physical and occupational therapy will go to their house to help them get dressed and learn to move around their house with the goal of, being independent in 2 months. And that might not be an ideal setup for home health for a palliative care patient, depending on what their goals are. And of course, that's depending on what their goals are. I think I would need a little bit more information for sort of when we're talking about ADLs. I do see that home health does help with ADLs. And again, a SNF is a different designation, or skilled nursing is a different designation, but I think that's about all I can offer right now.
Now, I'm just thinking in terms of potential actuarial analysis for Medicaid and which services basically are going to come up in the all payer claims database. Like, we already have coverage, we already have reimbursement for, which is what's the marginal cost of new services.
Hey,
Right? So
this is Ryan. I'm sorry to interrupt. I can provide a little insight on the Medicaid side for personal care. Now, this is going to be from my Utah days, but when I was working with home watch caregivers in Utah, and it was nothing but Medicaid benefits, and it was long-term care, the frequent ER visits, things like that. And so they did have to have a health disability that required a CNA or a home caregiver to go in and help with some ADLs. What Medicaid would not cover during that time was any house cleaning, any cooking, any laundry, any activities that would be very beneficial if it didn't coincide with the direct care. So if you showered somebody, you could help clean up the towels. If somebody wet their bed, you could change the sheets and things like that. And then with the home health side of things, it really is, as I call them, the outlier cases, where it is those long-term care cases with the catheters, with the ostomy bags, and things like that, that it is the skilled medical care. The problem that I came across with the home care was, if there was a skilled home health agency coming in for Medicare, we would have to pull out. So you could not have both services going in at the same time. And so there was the kind of the double dipping, as some people viewed it. And so there is a big gap between what home health can provide and what the Medicaid services were providing in Utah. Now, obviously, Utah and Washington are different, but there is some things from like Visiting Angels and Home Instead and Home Watch and some of these more, I think even like Catholic Community Services, some of these other entities out there that are providing caregiver support that might be dealing in Medicaid in the state, which I currently am not, but that is just a different avenue.
Thanks, Ryan. That's really helpful to hear. And I would have to look more into sort of the Washington side about delivering of like cleaning and cooking services. Those are usually not covered in Medicaid, which is a healthcare benefit. But I know, for example, our Health Homes program does a lot of linkage with some of the community-based organizations that you referenced, or alike organizations. So I think that the Health Homes benefit helps in that way. And I think that's why some states like Maine have used palliative care as a layer on top of the Health Homes benefit, but that's a Medicaid specific benefit. I see a couple other hands.
Yeah, I think Chris and then Bea. I think Chris had his hand up first. Go ahead, Chris.
Dr. Miller, thanks. Can you tell me, when we look at patients who are getting palliative care, how tightly grouped their clinical needs are, or the resources that they're necessitating, or is there just lots of variability? And I ask this because the suggestion of a PMPM payment, it's great if, all of these patients need 20 hours worth of care spread throughout the month, because that cost is going to be really close, versus, some people need 2 hours and some people need, 300 hours. It has its own pluses and minuses when you use a PMPM for, a group of patients who have a lot of variability there. And then also you had mentioned that Hawaii has brought this benefit forward. Do you know how they're paying and reimbursing for it?
Yeah, so Hawaii is doing a PMPM. I don't know all the details of that. I don't have data to show you about the sort of scope of services that a palliative care patient might need. I can tell you that this is why a tiered benefit approach has been one that we've thought about and looked into. Other states are doing that. I think there's a group at Minnesota that's looking at tiered approaches. So to your point, there are some patients that are going to need 5 hours a week of palliative care support, and there are some patients that are going to need 20. And so having one payment might not make sense, or even like group of services eligibility, et cetera. And so that's why we're looking at different tiers, or we've thought about different tiers. Does that answer your question?
Yes, awesome. Thank you.
Okay.
Go ahead, Bea.
Hi, B. Richter from DSHS Aging and Long-Term Support Administration. And I just wanted to respond to the home care questions. Personal care services is a benefit provided under Medicaid. A lot of the eligibility that you described, having functional limitations, serious illness and ADL need, probably dovetails quite nicely with the Medicaid personal care benefit offered through DSHS. I think, just offer myself and our team, we'd be happy to sit down and talk with you. A lot of it is referral and making sure that we make the connections. Ryan is correct that you do need to have a need with an activity of daily living, which could be as simple as bathing and medication reminders. And then when you have that, you also have assistance with housekeeping, errands, meal preparation, and those types of things. In terms of the per capita, our average per capita is $4,000 per month per person for in-home care. That's a lot of hours. Obviously, some folks may not need that number of hours. We also have smaller benefit packages under our 1115, which would include just housekeeping, but also personal care services that average more like $700 per capita per month. So, I think to build it into a PMPM would significantly increase, obviously, the PMPM. Another approach would be simply to partner closely together to ensure that people who are eligible for the personal care benefit, get access, and we can coordinate that care. And in Washington, we are able to have a Medicare certified or even a Medicaid certified home health agency providing services for the same person in the same month that is also receiving personal care.
That's so helpful. Thank you so much for sharing that. There's a, oh yeah, thanks Barb for sharing that about the Hawaii group. We've talked to them a few times. I think one of the challenges, and I don't know if this will be true for the commercial side, but there's parts of the Medicaid delivery that is pretty siloed. And so kind of, reaching out to folks in different, we talked to the health homes folks a few times, but that's been really important in figuring out sort of what services we already cover that might not actually be in a benefit, but it's covered in this sort of fragmented way.
Thank you so much. And I really apologize with the pronunciation of your name, B. I've seen your email and we've emailed, but I'm
No worries.
So sorry about that.
No worries. Yeah.
Okay, were there any other, I'm not seeing any other hands. I would say we have time for maybe 1 or 2 more questions, and then I want to get to our update on the procurement, and this is related to all of this, and then open it up for, tell you what our plan is for future meetings and open it up for any more input. So last call for any questions for Sophie. Hi, Greg, go ahead.
Thanks, Dr. Miller. You may have said it and I missed it. What is the timeline to where you estimate actually kind of this project coming to a conclusion?
Yeah, I didn't mention it, Greg, because I don't have, or Dr. Van de Kieft, I realized you called me Dr. Miller. I don't have a answer. So the Serious Illness Institute wraps up in about 4 months, I think, 4 or 5 months. So we do have some more time with them, and we don't have, quote, the data that we have back from them yet regarding potential utilization, et cetera. I think the question, remains is where to go after the Serious Illness Institute wraps up in the context of the challenges that we've had related to funding and other priorities. And I will be out on parental leave starting in 1 week. And so Jamie Tudeberg, who all of you know well, will be taking over the palliative care work during that time.
Thank you. And have a great parental leave.
Thank you.
Okay, wonderful. Thank you so much again, Sophie. That was extremely instructive for me and really helped get some more background. So thank you. And
yeah, thanks for having me.
Continuing to try and collaborate and partner, and that's what we're going to talk about next a little bit. So, and I'm going to invite my colleague Jane Beyer, who I should have introduced at the top of this meeting, who you all know, to help me with this next section. Basically want to give you an update on where we are. As you may recall, the legislature appropriated some funds to OIC to help us as part of this work group. The key part of that is getting an actuarial analysis to look at per member per month costs and have a better idea of the potential cost and impacts of a palliative care benefit. So that's really what we are aiming to secure. The legislation itself is asking for this study and any recommendations that applies to the commercial market and specifically the fully insured commercial market, right? But given everything that the HCA has been doing in Medicaid, our aim is to be able to secure this analysis that's as broad as possible and, if possible, can apply to Medicaid. So where we are in this right now is we've issued a request for proposals because we have to go through our competitive procurement process here at the OIC, and it does take a little bit of time. We've issued that request for proposals. We've asked vendors to come to us with 2 cost proposals. The first cost proposal is for the commercial market to model a benefit in the fully insured commercial market. The second is to model a benefit in Medicaid. So we have those proposals. We're in the process of evaluating those proposals. A consideration is the available funds OIC has from our appropriation to be able to get that analysis for basically both components. And, we want to be as coordinated as possible and try to have this analysis and this work be of value for the legislature for all of those populations. I can't guarantee that we're going to be able to add Medicaid right now. We're in that process, and we'll keep the group updated, but that's the aim. Let me pause there, and Jane, who knows this very well, let me see if you want to add anything onto
Nope.
what I just said.
Good job.
Okay. And the request for proposals, I had sent in an email to the work group. So anyway, you have that in case you're interested. We basically took the legislation and then put that into our procurement. So related to that, I just want to tell you what we're thinking about future meetings and where we go from here. So we have a tremendous amount of clinical expertise in this work group, and people have been working on this stuff for many years. I've had a couple of volunteers or presenters who are clinicians specifically. I know Dr. Van de Kieft and I think Marcia has some information about a palliative care staffing model, who have both been willing to present to this group. And so what we are thinking is to do another work group meeting. I'm thinking probably before the Christmas holiday, because it will be hopefully by that point, or hopefully before that, we'll be able to have the contractor on board. That'll be very important. So those are kind of the two next agenda items. So I want to get the presenters who have volunteered, particularly from a more clinical perspective, to be able to inform the group about their work, and hopefully that will be useful. And I also want to get the contractor on board and participating with the work group. And I think that one, well, I would say just kind of a central consideration in that is what are we going to have the actuary model specifically? And that's why I wanted to hear about the different ideas and recommendations regarding the services included and the PACC model, because ultimately we're going to have the actuary pull data from the all payer claims database, the APCD, to look at that commercial market data, potentially Medicaid data as well, right? And model specific assumptions. So that's what we as a group, I think, want to aim for. So those are kind of the ideas on the next steps. Jane, do you want to add anything?
Yeah, I think having those additional insights and the reference that we had to PACC and Ryan's comment about medical necessity and how that plays into all of this is, to the extent that we have something more definitive about sort of what the medical necessity criteria would be in looking at eligibility for the benefit, in a way that the higher the quality of what we'll get from the actuarial analysis. So having that, maybe a better understanding of PACC, and just what we want to do is we want to try to be able to give the actuary as much good information as they can. So, right, that their model, whatever they're modeling, gets us the best information we can about potential net costs of a palliative care benefit, given that a number of the services, as we've indicated, are already being covered by private insurance, but on sort of a piecemeal fee-for-service kind of an approach.
Right. And they'll be modeling the marginal cost of services that would be new, basically. So kind of having that difference will be really important.
And then I think we explicitly put into the RFP looking at APM for.
Correct.
Yep.
The legislation, I'm trying to remember whether it specifically mentions payment models, and I think it might mention something about an alternative payment model, but what we asked for in terms of the actuarial work is that they model at least one alternative payment model. So that's where we have it set. So we've set that floor in terms of what will be included in the work. Go ahead, Jim.
Sorry, just curious. A number of these models use functional status as an indicator, like palliative performance score or ECOGs. Do you feel like the databases you're referencing actually capture that?
Yeah, I mean, the
And if you don't know,
APC,
that's
I think, Jim, a lot of it depends upon what CPT codes tell us.
Mhm.
So which one should we use? How much is, I do not know enough about CPT coding to know whether it does or doesn't integrate that kind of information in any way, but it's a point really well taken.
Barb?
My question is about what is an alternative payment model? Is that alternative to fee for service? Is that what that means?
Yep.
So like a bundled payment model per member per month is an alternative payment model, right?
Yep. Mhm.
Okay,
Yep.
thank you.
Anything that's an alternative to fee for service. Yep.
Yeah, gotcha. Thank you.
Okay. Thanks for your comment and suggestion, Leslie. And I think we have a DOH actually representative that's part of the work group. So I appreciate that thought, and we can think about that for lining up future speakers. So, oh, go ahead, Jennifer. I see you raised your hand. Hi.
Hello, my name is Jennifer Curry. I'm from Regents, and I'm really particularly interested in the APM and how we're looking at that, because we're right now looking at that internally because we realize palliative care physicians, the fee-for-service model doesn't particularly work. And I'm just wondering, do we have anyone in this meeting who deals with APMs or writes APMs or can give us, there may be, I just don't know. I'm just wondering if there's anybody representing that faction that can help give some insight.
So Jennifer, it sounds like your question is, do we know of any payer that's implemented an APM model for palliative care?
Mm-hmm. Yeah. Yep.
Okay. Yeah, I mean, we can potentially ask the actuarial firm whether
Okay.
they can do some research around that. But if anybody does know of a payer that's using it, that would be great information for us to have as well.
We're looking
Mhm.
and we have some ideas, right? But I just
Mhm.
wonder if there's anything already kind of built out there that we could take a look at. So
Jennifer, have you looked at any of the work by Tori Fields when she helped California develop their public plan? Is that the sort of
mm-hmm.
thing you're thinking of? Or are you looking for something more specific?
I can take a look at that again. It's been a while. It's that we looked at that, but I just don't know if anybody's built anything out recently.
And the PAXI model that has been referenced was designed as an APM to try and get into Medicare through CMS, but
Mm-hmm.
it got to kind of the last leg of the journey, but didn't get all the way through. And so
Okay.
that if you do a deeper dive into PAXI, that may have some good information as well.
Okay. Cool. Okay. Thanks.
Yeah, really good question. And that's going to be part of this. Okay, let me see if there are any other hands that I missed. Okay, I'm not seeing any. So let me just ask for, based on what I said about some of the folks who had volunteered or interested in presenting to the group, and maybe having some presentations that are more clinician focused. And one of the examples was some of the staffing models being used. Let me just kind of get the group's input on if that sounds like a good approach for a future meeting or two meetings, if there are other suggestions that folks have for information, presenters, for the work group to look at. Did you have your hand up, Dr. Fausto? No, okay. Okay. If I don't hear anything, I'm assuming that we're okay with this direction overall for the future meeting. Okay. Barb, go ahead. Yep.
Yeah, I'm okay with the direction. I'd also love to hear insights from anybody, and I don't know that we have anybody in the work group, but if they have insights, if they have run or tried to run a community-based palliative care program that ran out of funding, or wasn't allowed to continue for lack of funding, or whatever it might be, and what their insights are, like what are the issues, and typically, I mean, I hear from providers that it's typically funding. You can't sustain something that's based on philanthropy or foundation funding because you're not able to bill for, say, nursing case management and or chaplain services. Now, chaplains do have a HCPC code, and that was one of the big issues before. But as of, I think, a year and a half ago, I think chaplains do have a HCPC code, but still, I don't think that it's reimbursable under Medicare's fee-for-service model. But anyway, and I'm not asking for anybody to jump into the fray, but if anybody has any of those kinds of insights from past experience, I would love to hear about it. Thanks.
And Barb, what is a HCPC code?
Oh, it's the way you can bill for services typically under Medicare. I don't know what it stands for. HCS, PCS. It's a specific code, like a home health or a hospice. Even though hospice is paid per diem, you still have to put all the disciplines down and their HCPC codes to sort of show what their visits were. It's a way for the CMS to track visits and collect more data.
Good. And Nico, I referenced Tori Fields earlier. We had reached out to her at one point because she's done so much work in this space, and she's kind of a nationally recognized expert, and she was agreeable to potentially meeting with the group and providing some of her experience, if that would be of value.
Yes, thanks so much for the suggestion. And I was chatting with Sophie, who I think has worked with Tori as well. So yes, I would love to include Tori in a future presentation. I understood she could maybe give some insight at a high level into considering benefit design. So yes, appreciate the suggestion.
Good.
Yep, go ahead, Marcia, and then Jim.
So I wanted to just say that my presentation would just be based on what we've tried in our community-based palliative care program. We don't exactly meet Barb's criteria of having closed entirely, but we've certainly shrunk over the last year and a half. So mostly because of challenges in reimbursement, which impacts staffing. So I don't know how to fix it, but I have some experience with the challenges, so I'd be happy to share that.
Wonderful. Great. Thanks, Marcia. Okay, go ahead, Jim.
Yeah, I was sort of elevating a request from a group I met with this week. There's a group who does outreach, palliative care outreach for folks who are insecurely housed or unhoused, and they noted some of the unique needs of, like, when people are at end of life in particular. If there isn't a caregiver, hospice won't engage. If there isn't a home, hospice won't engage. And so they had just asked that I echo to this group, if we are thinking about a benefit, trying to be as inclusive of those folks as possible. And not that we need to have an answer to that today, but I just want to bring that lens to the table and make sure it's part of ongoing conversation.
Did you say the name of, maybe I didn't catch the name of that group, or?
Yeah, so at UW we have a home outreach, palliative care outreach team for the homeless, I think is what they generally call themselves, but they're a sort of they're a foundation funded group. It's a social worker, a nurse, an NP, and then administrative support that help with the team who goes out and sees people in their cars, on the streets, sometimes in temporary housing, things like that. They just made it very clear that, like, at times, like, these folks don't have access to hospice because hospice needs a caregiver 24/7, or they need a home 24/7, and that doesn't quite serve this population. And it may not be
Okay.
something we can address, but I think if we can, or have thoughtful ways to support people doing work like that or more work like that, given the sort of challenges we see in Washington State with folks who are insecurely housed or managing multiple social determinants of health, I think would be important to consider. Thanks.
Okay. Great. Thank you for the suggestion. I appreciate that. And yeah, I think that we can consider we can try to consider that as we're getting the contractor on board and continuing conversations with this group. And certainly if there's, you know, an individual or an organization that, you know, you feel wants to participate, that's welcome as well. I mean, it's not just open to the work group, the public is invited. And I'm sure there's some organizations that weren't, the legislature didn't name, you know, on the bill that are interested. So thank you. Okay, I'm looking to see if there are any other hands. Okay, I don't see any. So it's 3:26. We're getting close to the 90 minutes. So I think that the next steps for us are to put together the next meeting, and we are aiming to have the contractor on board soon. We've gotten a lot of good input and suggestions and information and sharing of information across people in this group who have been working on this for a long time. So I really appreciate that. So we're going to work on the agenda and the future meeting and the procurement from OIC's part and gather together the input we've gotten today. So I think that that's about it for today. Jane, do you want to add anything before we close? I'm just trying to think of all the pieces of this to make sure that I'm not missing something.
No, I don't think so. Definitely. Thanks for the thoughtful discussion. I think one of the things I like about the fact that we're recording these sessions is when we get the actuarial firm under contract, probably the first thing we'll ask them to do is to listen to these first two meetings that we've had and then attend the future meetings of the work group as well. So we really appreciate it.
Thank you. Wonderful attendance and questions and comments. Okay, well, we're gonna end it there, give you 2 minutes back. Thanks again, everybody, and talk to you soon.
Thank you.
And we can end record.